Thank you. You're going to have a very long wait list for new patients to come and see you, I think, after that. We have some time now for question and answer for these amazing speakers. So I am seeing a hand up over here, and I see a volunteer coming to you. Keep your hand up, please.
Hello.
There we go. We're going to get you. Now I hear somebody, but I don't see you.
Marco.
Ah, Polo, got it.
Thank you so much. I actually have a comment. Those who have met me, I live in PA and my stepson lives 2 hours away in New York. We're very active in his life. And I just recently discovered in New York State for the guardianship, he qualifies what's called the 17A, where 2 doctors and a psychiatrist signs off that he has a disability, TBI. There's one more thing, but as long as they foresee it never getting any better, then they would qualify under the 17A. So I'm not sure if the state that you live in has something familiar, but we were scared to death to know once he turned 18 and the process of the paperwork that if something happened, our son is also nonverbal, so he wouldn't be able to approve treatment himself.
Thank you very much. So one of the great things here would be to share tips like this. And I saw in the big room over there, there's a board on the closest side of the wall that has share your tips. And there's already some great ones, so please keep adding those. I think that'll be terrific. Right down here, yeah.
Hi, I just wanted to take a moment to appreciate Dr. Haridas. It was a year and a half ago that we had a meeting with you at Johns Hopkins. My son, Ishan, was going through a lot of seizure activity in school, was only at school, and we consulted the neurologist, and she kind of dismissed it at the time, indicating that he's probably acting out. So we sought to get a second opinion. We saw you, and luck would have it that 60 minutes of time spent with talking to you, understanding, going over the history, all the things that you mentioned, we actually lived through it because you were asking us all those questions. I don't remember if we brought in the chart sheets, but we had a lot of data. As it would have it, you happened to see the seizure in real time with Ishan, and you sent the emails out to our doctor saying that this is some real stuff happening here, so let's not brush it off. Within 2 months of that visit, he was diagnosed with LGS, and the journey has not been simple. I just wanted to acknowledge and thank you for taking that time and listening to us and listening to our concerns and making it so that we're not dismissing our child and listening to the adult only. So thank you.
Thank you.
Thank you, guys. I've actually been thinking about you guys. We should touch base offline. Yeah, thank you.
Me, right? Okay, so, hi, sorry. Hi, everyone. This is our first conference. First, I want to say thank you to each and every one of you for being here. Sorry, I have a loud voice. So the 4 of us, we have another daughter and Dean here who's 18. And I think my question for the panel, Jennifer, you mentioned this and it got me thinking about it. One of our current struggles, Dean is incontinent, but the bladder retention, and I can't tell if it's an issue or if it's even a known LGS issue around, is the brain not connecting to the bladder in terms, so what he ends up doing is, in brass tacks, not urinating all day long, and then he gets this big dump of urine later in the day, and of course you can't predict it, and of course you're always in the car, and there's no diaper that will hold this amount, and he's not dehydrated, so because he has a G-tip, so we know what the fluids are, the ins and outs. Is this a known thing in LGS? Our neurologist seemed a little surprised, so I didn't know.
I just saw 3 heads nod. Do you guys want to talk about it?
It looks like
Can I just say that, so we have a Caregivers of Adults support group that meets monthly.
Oh, wow.
And it's on Zoom, and it's the 4th Monday of the month, 8 o'clock Eastern Time. We can get you involved in that group.
Fantastic.
And that group, we really have a lot of, the conversations are really good. Like they've been lately we've just had, so we're talking about some real stuff. And I mean, not that the other groups aren't. I mean, it's just that because we've been doing this for so long, we're getting in depth about it. And that group practically insisted on more information on that particular subject.
Fantastic.
And
Yeah.
just know that that information is actually is being worked on and is coming. We're going to do like a one-pager on urine retention. My son just holds it in all day.
I can't
and I'm
tell
sure
if
that
it's
I would
that
get
or-
a bunch
yeah.
of bobbing heads all over the place. And then when it happens, it's just like it's like
a
lots of
floodgate.
laundry, lots of laundry afterwards, and
Yeah.
double diapers, you name it, sheets and everything. So it's very. I think it is not uncommon in our community, and it's we'd love more information about it.
Okay, thank
And
you
we're
so
trying
much.
to get you some.
Yeah, thank you. Yes.
The other thing that I would say is I've learned to be humble about the things that I know and don't know about side effects of anti-seizure medicines. And there are rare side effects of some of the medicines that do affect urinary tract. So it's worth asking, but then asking your doctor to look in the literature for case reports and other things. Because I have said absolutely not, this can't possibly be a side effect
Right.
of some things, and been completely wrong.
Yeah. Well, and just a really quick follow-up question with that. We have a great neurologist, and I think he would be willing to look into it further. Do you know if it's a medication side effect? Because we're all on like 50 gazillion meds, right? Sorry, is it connection with the brain and the nerves going to the bladder? Is that kind of where the side effect happens? Or because I really, in his case, I don't think it's behavioral. And my husband gets very frustrated with it because he thinks we go to the bathroom, he tries to do time toileting, and I just do diapers. That's easier. But that's why I wanted to be able to explain, or do we not quite know yet?
It's going to depend on the person as well as the specific medicine.
My son is 9 years old, and we've only ever received care at a teaching hospital. Just wondering the pros and the cons between being seen at a teaching hospital versus a non-teaching hospital. Some of our inpatient stays, it feels like they could be prioritizing the doctor's teaching experience over our medical experience there. And also in those situations, how can we advocate for our child and also have the balance of the teachers also, or the doctors also experiencing the teaching while in the hospital?
I think that's a great question, because especially as we talk about, clinical care for our LGS community as well as research, a lot of times many people might actually be at teaching hospitals. So I think it really, being that I'm at a teaching hospital, I can also say that it's important to make sure that your voice is heard. So ensure that your questions and concerns are being addressed. A lot of times when at a teaching hospital, what I've noticed is that, especially when I'm supervising resident clinic or fellow clinic, they ask me a lot of questions. They keep me on my toes. They ask me about why I'm saying, this particular, we need to consider a medication, let's say like, I don't know, whether if we need to consider fenfluramine, or why I'm suggesting that we should think about calisotomy in a patient, or an RNS, and what the data is. So there may be at least in our team, I can attest to the fact there's a lot of discussion that happens behind the, as our families' stories are being discussed with me when I'm supervising a trainee's clinic. But I think at the end of the day, there needs to be an in-depth discussion of why these options are being discussed or being brought up to you as the one that is taking care of this precious one with LGS. And so that again reiterates what I was saying earlier about how fundamental care is essentially making sure that your voice is heard, your concerns are being heard, and that they're being addressed. So.
Yeah, I think The other things that I would add on, and full disclosure, right, we both work at teaching hospitals, but the reality is that pediatric neurologists, the vast majority work in academic health centers, which means teaching hospitals. And that's where the research is happening, that's where the breakthroughs are gonna come, and that's where the most advanced care, for the most part, especially in pediatrics, is happening. So I wouldn't shy from a teaching hospital. The other thing I know is that when you go in and you're admitted to an inpatient service on a teaching hospital and you meet the medical student and they ask you questions, then you meet the intern and they ask you questions, and the resident and the fellow and the attending, I know it gets frustrating. Here's the thing. You never know when somebody asks a question just a little bit differently that breaks everything open and helps us make a big leap forward. So wherever you can, and I know it is hard, wherever you can, have patience there, because I have seen sometimes when that medical student or the third person who took the history comes out and says, hey, I learned this other thing and now I have a new question, and I can come at it from a different angle. So try to have some patience. Know that they're doing the best that we can, and the only way to make other people know about LGS is for them to meet you, right? And to really live it. If they look at it in a textbook, it doesn't mean anything. To meet you and understand your story means a lot. We can't have our healthcare providers be afraid of kids with LGS. And what happens if they don't meet you is they're afraid and they don't know what to do. So help us as a community. Yes, way in the back, I see someone. Oh, and we'll go in the back and then we'll come up front.
Am I the one in the back?
Yes.
Oh, okay. Hi, thank you, panel, for coming out here. We really appreciate you dedicating your lives to serving our community. And the parents, we all can relate. I'm very thankful you guys shared your stories. My concern is the transitioning to adulthood. So my daughter Gia, my little angel, she's 21, about to be 22. We just transitioned from our pediatric neurologist at Phoenix Children's to St. Joe's Barrow Institute, also in Phoenix. I can share my experience. You both are pediatric neurologists. You can tell with your passion and your gentleness and your wanting to share your stories and your knowledge. And that's how pediatrics is. We're always a team. Everything, you've seen our children for 20 years, from babies, go through LGS, and then what happens is we transition to adults. We transition to providers that made that decision when they were in school to only do adults. They have one rotation with pediatrics, but they're with adults because that's what they want. So they don't have the 20 years of experience. They just see LGS. They are a lot harsher. They are a lot not softer. And it's not just with neurology, but it's with GI. We have chronic constipation. I have the most wonderful GI doctor at Phoenix Children's who will talk to me an hour about constipation and in detail. You go to adults, they want to scope. They want to do scopes. Pulmonology, the same way. We can talk about different breathing treatments, what we can do, the CPD and all the different stuff to gently take care of our child. You go to adults, they might want a bronch. The mindset is completely different. There is a gap with our children. If there was a way to do, and now I hear that they're doing bilateral, like pediatric and adult specialists, but there's just not enough. And it's where we get this great support from pediatric hospitals, and then like Boston, Johns Hopkins, and University of Washington, like that's a big brain school. You guys, we go through this journey, and then it's adults. It's adults, and what they're usually dealing with is stroke, elderly, dementia, the seizures for that field. There's a huge gap, and it's not. We can keep getting pushed out, but it's like, man, these are our angels. We've fought 20 some odd years to keep these kids alive, giving them the best. I'm here from Arizona. This was not an easy trip because she deserves the best. But those providers that, I'm a nurse. I can talk, no problem with them, but I see this gap, and it's something else. I don't know how we fix that because it's everywhere. Sorry for the long run on.
No, I completely agree. And, you know, this was one of the 3 grand challenges that we heard this morning, right? Lifetime care. The reality is that the medical field is catching up, right? Thank goodness our babies with LGS are growing up, right? And we're not prepared. We'll own it, right? We're not prepared. We're working on it. It helps a lot to have the advocacy of LGS Foundation, of people like you, and other families of kids with complex medical needs. We've seen different specialties attack this from different angles, right? The cardiology world has a whole new specialty of taking care of adults with congenital heart disease. We haven't seen that in neurology yet. I'd love to see it. But this is gonna take a long time. And the other thing that I would say is, oftentimes what I'm seeing is an institution will have the one person who's the transition person, which is fantastic. Those people are all in, they're great doctors. How long will it take before their clinic is completely full? They're gonna have to transition them out to sort of regular adult care too. So we need a longer term plan. We're not there yet. We got a lot of work to do.
Hi, this wasn't planned, but we are transitioning this year. So our first meeting with the adult neurologist was in February, and we have been also in the middle of tuning up the DBS because it was just installed last August. So one of the things that Colorado Children's has done really great was over the last 5 years, they've been building the notes page on the MyChart and Epic. And one of the things I did before we had that first meeting and had left the other was to actually just read that notes page for what was in there and what was missing. And the only thing which we have given feedback back to Children's that was missing was actually the history of the med list. And for some reason, the doctor, they hadn't transitioned the records yet, so she literally had no history of any of the medications going into that first meeting, but I had scribbled them down along with sort of a rough up or down, and she was like treating that like gold. So that's one thing I think we can do is just to help the people coming behind us is to just think of it from an improving mindset and giving that feedback to continue the loop of making that better. Actually having Medtronic at both meetings, because they just go back and forth between Children's Hospital and UC Health, like kind of all week, that actually made a perfect bridge. So the one person who was leading the program was in the first meeting with Children's, and then they were at the meeting. And so we're having some other little hiccups, but I consider them to be minor compared to, I mean, the one big thing has been I'm used to being able to call neuro on call. And for some reason, it's a little bit more complicated at the adult level for what do you do in the middle of the night when your medication spills and you need an emergency prescription refill. It's not that clean yet, but we're working on it.
Thanks for sharing your story. I see a mic up here now.
Hi, so thank you for all your time and your dedication. I think everybody in here probably has their own, day-to-day struggles and day-to-day victories, but I think one thing that we all share is the fear of SUDEP. Is there anything being researched about it? Because that is like the one thing that I think probably can bring any family to tears, either because it happened or the fear is always there.
So, of course, I think this is one, while we all have many ups and downs on a daily basis as we go through this journey together, this is what our biggest fear is, right? There is, if I can share some, hopefully a little bit of positive news in this context, is that there is research that's going into this. I can share that we're not publication ready yet, but my team, we're looking at, being that we have both adult and pediatric patients admitted to our center, and we're gathering all of that EEG data, and we have their entire charts. We're actually in the middle of looking through the question of incidence rates, risk factors, EEG parameters in our LGS loved ones who have sadly lost to SUDEP. So This is in the works, and I know some other centers are also similarly looking at SUDEP, and I'm hopeful that in the next couple of months we'll be able to publish this data.
And know that there are lots of people. I think one of the good things is now we don't like saying it out loud, but it's allowed for us to say SUDEP out loud in public, right? And we need to. And the more we do it, the less we're scared to at least have a conversation. There is a group called PAMI, Partners Against Mortality and Epilepsy, that has a big conference ahead of the American Epilepsy Society meeting every year that's focused on preventing epilepsy and preventing mortality and epilepsy, which of course a big piece of that is SUDEP, and they have a very robust research presentation that goes on in that setting. So yes, we're working on it as a big epilepsy community. People are actively working on it, but we don't have the breakthrough just yet.
Okay. Hello, my name is Sarai. I'm here with my daughter Sarah. She's 13 years old. I have two questions. The first one is, exist another syndromes that can mimic Lennox-Gastaut? Because my daughter, we don't have a cause. After genetics, MRIs, we did everything. And I want to know if maybe it's syndromes that can mimic or can trigger Lennox-Gastaut, because we don't know. And the second question is, we saw that her seizures are better after VNS, and after we reduce medicines. Now with less medicines, she's doing better than before. My question is, if a medication is working better, that can help us to find out maybe a cause, like in the reverse. You know, sometimes you have the cause, you give the medicine, but maybe when you see this medicine is working better, because that can help us to find the cause, and if yes, who can help me to figure it out that so she can improve more? I don't know. I hope that you understand my question.
Yes, so I can get started and Renee can take it from there. But so I think this might require, perhaps like a deeper, longer conversation about the specifics in your guys' case, which we can discuss offline. But generally speaking, certainly when, for example, if I'm seeing a family in clinic and I see that a certain class of medications has been really helpful in controlling our child's seizures, then that makes me become suspicious about what the root cause of their epilepsy may be. Typically, as we had discussed, the workup for understanding what the root cause for the LGS is includes multiple different tests, including EEG imaging and genetics. A lot of times we see that with certain genetic conditions, there can be a favorable response with some classes of medications and even an unfavorable response or a worsening of seizures with certain classes of medications. So if we start to see similar patterns, then that's when usually in my clinic I start thinking about this. I jumped to your second question, but your first question was, are there any specific conditions that can mimic LGS? I think, as several of our conversations earlier had pointed out, in order for us to study LGS, we need to first define LGS, and that requires EEG and clinical features. This is where I think we might need to talk offline, because I'd be curious to see what EEG features have been identified thus far, and then we can probably expand on that. Do you want to?
The other thing that I would point out is we're getting smarter every day about genetics. And so genetic testing that was done 5 years ago is outdated, right? And so it's worth, if you did some testing a number of years ago and you don't have an answer, it's worth going back to say, hey, can my test be reevaluated? And sometimes they can do that without even having to take more blood or sort of doing a procedure at poke on your person with LGS. Sometimes the lab still has the sample and can go back, or has the data and can go back and reassess. So reevaluating genetics every few years is a reasonable thing if you haven't gotten an answer yet. All right. I'm not seeing another hand waving at me, and we are really close to exactly what time we said we were going to end, so I'm quite proud of all of us for keeping this together.